Hello and welcome to this GSA and Alzheimer's Association Link AD webinar. This is the first in a series of 3. It's my pleasure to welcome you to this program, Personalized Goal Setting in the Clinical Care of Persons with Cognitive Impairment, Measuring What Matters Most. My name is Jen Pettis and I'm the Director of Strategic Alliances for the Gerontological Society of America. We'll start with a few housekeeping things. First, if you would, introduce yourself in the chat. We'd love to know who's here with us. We are recording this conversation and we will make this available on GSA's website along with the slide presentation. Please keep yourself, your video off and your audio muted until it's time for discussion. We will use the chat throughout the presentation where you can comment, but you're also able to ask questions there. We don't use a Q&A separate tab. We just use that chat. You can also flag technical issues there, and myself or one of my colleagues at GSA will try to help you resolve any issues. And if you like the program today, please join us and invite friends for our future programming. We've got 2 more of these sessions, one later this week and one next week as part of this series. And then we always have other webinars going on as well. And with that, I'm going to turn it over to my colleague, Sam Fazio. Oh, no, I'm not. I'm going to remind you about the GSA annual scientific meeting. We are going to be in Tampa, Florida on November 8th through the 12th. And I do want to remind you that abstract submissions are open through March 9th. So please get those abstracts in. Tell your friends. The venue in Tampa is beautiful. It's right on the ocean, so kind of a resort feel. And we hope that you'll be able to join us there. And this time, I am going to turn it over to my colleague, Sam Fazio from the Alzheimer's Association, to introduce our speaker and tell you a bit about Link AD. Thanks so much for joining us, everyone. Sam, go ahead and take it away.
Thanks, Jen. Yeah, I wish we were in Tampa today. And I bet you do too with all the snow you're getting up there. So welcome, everyone. I'm Sam Fazio. I oversee quality care and psychosocial research at the Alzheimer's Association Home Office. And I am the PI on a grant called Link AD, along with Dr. Cheryl Zimmerman, which is really a consortium of researchers looking at person-centered care and measures that are person-centered care. So I wanted to tell you a little bit about Link AD. You can find out more about it at alz.org/linkad there on the screen. And we have a lot of different opportunities all around person-centered measurement. There's call for papers, which are part of supplements in our Alzheimer's and Dementia journals. There's different funding opportunities looking at again, measurement through our international grants program, networking events at other conferences, including GSA, and webinars like this, which is a great collaboration between us and GSA to really share what we're doing and bring our members together. So like I mentioned, you can see a little bit about Link AD there on the right, but it really is to look at what's out there in relation to measures that are person-centered, and to really promote the development of them and different care tools to fill in those gaps. And then have a system in place to disseminate all that information through our website, through a repository, through a GAIN database where there's data sharing, and then, like I mentioned, through all of these things on the left here around papers and talks and grant programs. So I'm going to stop there. Please feel free to email if you have questions, and I am going to introduce Dr. Lee Jennings, who is going to talk about around goal setting and is really the person around this topic. We've talked to her many times, and I know some of you have probably seen her in other arenas. So Lee, I'll let you give a little introduction of yourself so that I don't just read your bio, and we'll take it from there. Thank you.
Thank you, Sam. So thank you guys first to GSA and to Link AD for the opportunity to be here today. It is really great to have the opportunity to talk about a topic that I'm very passionate about and interested in. I am a clinical geriatrician and a health services researcher, and I'm going to talk today about some of my work and work of others using individualized, personalized goal setting and goal attainment as outcomes, not only in dementia care research, but kind of starting to move into the realm of clinical quality measurement. So I have no conflicts of interest related to this talk today to disclose. And here's what we're going to try to cover over the next 40 minutes or so. I'm going to talk about two different approaches to person-centered outcome measurement that I have used in work and others have used around individualized goal attainment, and also using person-reported outcome measures or PROMs. I'm going to talk a little bit more in depth about some examples of goal attainment scaling in dementia research, and then also its use in clinical quality measurement. And then we're going to cover a little bit around research and best practices around eliciting personalized goals. They really have to understand what's important to people to then be able to set meaningful goals. And then we'll end with some ideas around future directions for research.
Hey Lee, this is Sam. I just wanted to interrupt for 1 second because I forgot to let people know that we'll handle questions at the end. And so feel free to go ahead and put a question into the chat box and I will monitor those and then ask Lee at the end.
Yep, sounds great. We'll be happy to take questions at the end. Great. So, why person-centered outcomes? And there's been a ton of work, I think, over the last couple of years, really moving this body of work forward, which is really exciting. But I think ultimately we're really trying to get around two large ideas in measurement. And one is, does the care, whether it's healthcare or community care or home interventions, does the care we deliver help individuals, people achieve the outcomes that are most important to them? And then the second kind of idea I think we're trying to get at with personalized goal measurement is, if we understand what's important to people, if we understand the outcomes that are important to them, are we recommending care, are we delivering care that's aligned with those goals? So do the goals themselves help us deliver better care, help change how we deliver care? And so those are kind of two constructs that I'm interested in trying to understand. I think others are too. And again, it's an exciting time in this work. There are lots of national bodies focused on here. I'm remiss actually not to have GSA and LinkAD on this slide, but just to say, IHI and the Hartford Foundation with the Age-Friendly Health Initiative have what matters most as one of their key tenets. CMS has done work in this around meaningful measures. National Committee for Quality Assurance, which I have done some work for them, and I'm going to talk a little bit about some of their work in quality measurement in this area. The NIA Dementia Research Summits, there have been two, and there's one coming up. They have all had recommendations come out of those around individual goal attainment and personalized measures for dementia care. So it's kind of an exciting time to see this work moving forward. So when I talk about a goal-oriented approach to care, what am I talking about? And this is just one schema. There are others to kind of how we might operationalize this. And first, it's around eliciting values and care preferences. What are important to individuals? And their care partners, their carers, their family carers in dementia is particularly important in this area too. Because then you can move into identifying a SMART goal. It needs to be specific so that you can measure it at a future time point. And then often the goal itself is not enough. There needs to be some action planning around how to actually achieve that goal. We're going to talk today predominantly about, if you've gone through this process, how you might measure goal attainment. Both in research, pragmatic research, and then also clinical care. And then ultimately, we know that this is a progressive disease. We know that, and it's usually almost never occurs in isolation. So people have other clinical needs, other social needs that occur, and we need a way to revise and reassess goals over time. And I think the issue with kind of the crux of the issue with the personalized goal attainment is this balancing of individualized outcomes with the need to have standardized, valid, reliable outcomes. And so I'm going to talk about two different approaches that one might use regarding PROMs and then also goal attainment scaling. So we talk about PROMs. There's two different ways to think about PROM measurement, right? So PROMs, often we use them to do a cohort measure, right? So this is sort of the average improvement in a construct over time for a cohort. We've also done some work around prioritized PROMs. We're trying to select a validated PROM that closely matches a person goal. And this has I think some pros and cons. And here's some examples of some PROMs that we might use. So around functional status or symptom control or quality of life, or caregiver aspect, important measures for caregivers around self-efficacy or positive aspects of caregiving. Pros around for PROMs, they're validated, right? We understand these tools, they've been used and validated. Many of them can be self-administered, which is nice when you think about translation to clinical care, pragmatic research. They're often good for symptoms. They can be followed longitudinally, right? So they're easier to compare across studies and health systems, but there's some drawbacks. So you can't always find a PROM that really well matches an individual's goal. So for example, there's not a PROM around attending a grandchild's wedding. So some of these goals are more idiosyncratic and really person specific, and we don't have a PROM that really matches well. And then sometimes the scale itself can be too generic and may not actually capture a small change that an individual is making. So a physical function, if the goal is around physical function and the functional change is very small, so improving transfers enough to be able to go home with your spouse might be a personalized goal. And there may not be a PROM that really well captures that change, that improvement. PROMs also may not fit well if decline is expected. Though sometimes that can also be a critique, I think, of goal attainment scaling. So that's something we work in measurement. And then OXO proxy reports. So this is I think a construct that's important to think through in dementia research, because individuals may have cognitive impairment, especially as the disease progresses, and it may impact how that PROM is recorded over time or who's recording it, and that can have implications for measurement. We're not going to go into that too much today, but just to say that it is, I think, an important construct to think about, or an important aspect of measurement. And then lastly, for PROMs, sometimes the qualitative meaning of the score is not super clear. And again, I think this has implications when we think about translating these research interventions that are well tested into clinical care. If the clinicians don't understand what the PROM score means, it's harder to know how to act on them. So that could be overcome with training, but it is, I think, a potential drawback. Okay, so that's one approach, prioritize PROM. Another way to think about personalized measurement is goal attainment scaling. So this is really, in goal attainment scaling has been around since the 1960s, and it's used largely in rehab research. We're beginning to see it used more in dementia research, which is exciting. And it's been used in mental health quite a bit as well. And it's really a way to take an individual's goal, make it specific so that it can be measured at a specified time point. And here's an example here below. So this individual goal is to interact more with grandkids. Their goal is to contact the grandkids once a month. And then you can also see what it would look like to exceed that goal or far exceed that goal. And what it would look like if, we really don't make any progress on that goal. This is where we are now. This is our baseline state. We're calling the grandkids every 2 months. And then also what would it look like if it worsened? And so in this way, it's a way to take a personalized goal, graded it out across 5 outcome categories. And then you can follow up at a future time point, and I understand, where are you now with this goal? This is where you started. Have we achieved the goal, exceeded, or have things actually worsened? So sort of a way to incorporate kind of all the possible outcomes for this individual's goal. And in this way, we were able to retain what's important to the individual, but the measurement of the goal attainment is standardized across a cohort. So that allows it to be something that could be used to measure different interventions. Do these interventions allow individuals to attain the goals that they had identified as most important? So I want to talk a little bit about individualized outcomes, which goal attainment is one example of that. Prioritized PROM could also be used, versus population or cohort outcomes. And this is, again, the construct of a mean score for a group of people. Does an intervention improve this overall for the cohort? And both are valuable, but I think there's sort of a compare and contrast. So goal attainment really is, or individualized outcomes, are really focused on person-specific goals, whereas this, again, is focused on improving an outcome for a group. This is important for population health. It's important for comparisons across interventions. But this, again, it may not fit the person's goal. It may not accommodate an very idiosyncratic, or person-specific goal, where goal attainment scaling can. But goal attainment scaling can be used for, it can be hard to use for some goals. So particularly we see this with mood or symptoms. We can often operationalize processes to try to improve depression, say, or treat depression, but it doesn't really depression, I feel somewhat depressed, I feel a little bit more depressed, less depressed, things like that. That doesn't really work well for that construct. And a validated PROM may actually be a better tool for that. Goal attainment scaling is quite responsive to small change, particularly if you're doing more than one goal, a couple of goals, whereas PROMs may struggle to capture those small changes. I will say, I think in some of our work, we've seen that goal attainment scaling, teaching people to do this well, does require more intensive training. And so again, I think there's pros and cons to both, but ultimately, I think both have value as outcome measures in dementia care and services research. And it's exciting to see the development of both of these outcome measurement tools. Okay, I want to talk a little bit about PROMs and research. This is an area where LinkAD is really leading the way, I think. And this is some work done by Dr. Riley, kind of outlining what is important to individuals with early stage dementia, and then kind of cross-mapping that to the measures that we have available now. And so what she did through some pretty intensive qualitative work was look at 13 core outcome domains that are important to persons living with a dementia, that was developed with input from over 300 stakeholders from a wide variety of stakeholder groups, including persons living with dementia. And then did a systematic review of existing self-report measures that are included in dementia research, and included 76 different self-report measures. And then this table here, figure 1, shows that final kind of core outcome set of 13 measures. And I think if you read through this, if you do work on this, it really resonates, right? The importance of relationships, being able to communicate with others, feeling safe and secure, feeling valued and respected, meaningful activities, right? It's important to me for the duration of my life to do meaningful activities. Dementia symptoms around apathy and indifference, alertness, understanding time and place, and quality of life, hygiene and comfort, being physical safety as you move about, not falling, vision and hearing, having a sense of who you are, having a laugh. And so I thought this was really important qualitative work to understand what's important to people with early stage dementia. And then this is kind of going through mapping the existing measures that we have to those domains. And what they saw was that the measure that had the closest matching to those 13 items was the Engagement, Independence, and Dementia questionnaire, but it only covered about 50% of those 13 items. So still a lot of opportunity, to do work to develop PROMs around measuring what is important to people with dementia. And then there are others doing this work, and I wanted to make sure we talked a little bit about the work that LinkAD has done. So this is Sam Fazio and Cheryl Zimmerman, and they have, the LinkAD is really focused on these 9 practice domains for Alzheimer's care and services, and then they went through and looked at examples of measures for care that could be developed, and then measures that would map to improving well-being of individuals living with dementia. And so I wanted to point out that there are others doing this work as well. And if you read through these works, they also are very, they resonate, making information available so that people can accept diagnosis and live in, and be able to move forward after hearing about the diagnosis of dementia and the challenge there. Performing regular comprehensive person-centered assessments so that people can be satisfied with care choices. So I thought this was also really important work. And here's the reference if you're interested. And then also would be remiss if I didn't mention that Dr. Riley's work will also be mentioned, also be highlighted in the upcoming NIA Dementia Care and Services Summit. So if you're able to tune in for that, you can hear her speak more about her work as well. And then I mentioned just those 2 examples of work and development of PROMs, but there is a lot of international work happening here as well. So LinkAD really focused on the development and use of measures that are person-centered, strength-based, that capture diversity, that are across the progression of disease. Really important that we have not just early stage, but moderate and late stage measures as well. And then pragmatic, right? Because ultimately we want to see these things transition from research to clinical care. The NIA Impact Collaboratory is another US US group that's working on this. They have a patient and caregiver relevant outcome library. You can go and look at existing pragmatic measures that are being used in dementia research. Interdem, which is the Early Detection and Timely Intervention in Dementia, is a pan-European network, also doing work in this area. And then JPND, or the Joint Program in Neurodegenerative Disease Research. And so ultimately, we want to see harmonization too, right, across all of these different efforts, so that we, ideally are measuring similar things, so we can understand what interventions help and who and how much, so that we can ultimately make recommendations to policymakers, right, to see these things moved into more into clinical care. So I want to switch gears now away from PROMs and talk a little bit about goal attainment scaling. So this is sort of kind of goes through some of the work that I've done over had the opportunity to do over my career, kind of how this work has developed for me. So we started off actually as a fellow and a brand new faculty member, doing some work on a PCORI methodology study, trying to see if we could use goal attainment scaling in a very clinical way in a dementia care management program at the University of California in Los Angeles. And we found that it was feasible and learned a lot from that work. And then that translated into a pilot study, actually, through our Oklahoma practice-based research and research network, where we used it in primary care in persons with cognitive impairment. And what we found there is clinicians really appreciated it. They liked it, but it was very hard to use. It added both value and time in primary care, and really required quite a bit of provider training to be able to use it. These two studies then informed work, as well as other researchers around work that in the National Committee for Quality Assurance, NCQA, is doing around demonstration projects, where they are really trying to focus on personalized goals as quality measures. And they have done some work showing that goal setting is feasible, particularly with care managers in persons who have long-term care needs and serious illness, which includes persons living with cognitive impairment and dementia. And then lastly, there's the D-Care trial, the dementia care trial, which is a pragmatic trial. I'll talk a little bit about that, comparing health systems based dementia care management, community-based dementia care management, and also a third arm of usual care. And they're using goal attainment scaling as a tertiary outcome in almost 850 participants. So we'll have some, that study is ongoing, so we'll have some data from that study about how well this works as well in a very pragmatic setting. So this is some of my work in this area. And I want to talk a little bit about that, but also talk about some exciting work that others are doing using goal attainment scaling and evaluation of interventions in dementia care. So this was our very first pilot, our very first study with funded by PCORI, using goal attainment scaling and comprehensive dementia care. And we had 101 patient caregiver dyads in this program. And we, as part of their clinical visit, actually asked them to set a personalized goal for their dementia care. We then followed up with them at 6 months and 12 months. And here's what we found, is that about 3/4 of people either met or exceeded their expected level of goal attainment. And we asked them about the process, and the vast majority, 85%, said it was helpful for future care planning. 75% or 74%, excuse me, said it was different from their usual care, offered something different. Just over half actually shared their goal or discussed their goal with another provider. I think that gets at that construct of, once we know people's goals, are we then aligning our care that we are offering to help them achieve that goal? And then 83% said they plan to continue to work on goals going forward. We also did some qualitative work as part of this. So we did some focus groups before we began the study to understand what was important to people, and then also looked at the goals that they had specified, articulated for us, and did some content analysis there. And I think, what we found was that, there were a few goals that sort of, fell into a medical realm, but the vast majority were about quality of life. And this was a population that had moderate dementia on average. So we had a lot of caregivers participating in that goal setting process as well. And there were important goals around supporting the caregiver in order for them to support the individual. And then now to kind of give you a little bit more about the D-Care study, which is this work helped kind of inform use of goal attainment scaling as a tertiary outcome in this study. So this is a 4-site pragmatic trial, 18-month, 3 arms. So here's, you can see the description of the different arms here. So we have a health system-based dementia care arm, which is based on the UCLA ADC model. We have a community-based dementia care arm, which is based on the BRI care consultation model, and then usual care, which is referral to the Alzheimer's Association. We have our goal enrollment was 2,150 dyads. We actually have 2176 enrolled, 1,000 in each intervention arm and 150 in usual care. And the primary outcomes were dementia-related behavioral symptoms as measured by the NPIQ and caregiver strain from the modified caregiver strain index measured at 4 different time points. And then we've been able to do goal attainment at 6. We also did goal attainment with the first half of participants with evaluation of attainment at 6 months, and then again at 18 months. And this is ongoing. This data collection is still ongoing. We completed enrollment as of January 2022, and we'll complete data collection as of September of 2023. But looking at some of the preliminary enrollment data, we've had almost 850 individuals of that first 1,000 set baseline goals. And then we've had about 75% who then rated attainment. We've actually had almost 20% of participants pass away in this study. It's an older population with a mean age of 80, and they have moderate dementia on average. But it was exciting to see kind of this large cohort of community dwelling individuals with dementia. It'll be exciting to see what their goals are and whether these interventions help them attain what's important to them. So that's upcoming. And then we're not the only ones doing this work and using goal attainment scaling. I wanted to mention the NIDIS family study as well. So this is the new interventions for independence and dementia study. It's a randomized 2-arm trial of NIDIS versus usual care, multi-site of about almost 300 persons and family caregiver dyads. The intervention is 6 to 8 sessions, either by video, telephone, or in person with a trained facilitator over a 6-month period, and then telephone follow-up for the next 6 months thereafter. The interventions really aim to support persons living with dementia and carers to keep people living at home for longer. And the idea is to address barriers that may precipitate moves out of the home. Their primary outcome, again, is goal attainment at 12 months, and they're setting 3 to 5 goals. In the DCARE study, we're just setting 1 goal. So 3 to 5 goals with individuals. And they have some very nice papers out about the trial, if you want to read about that, and about some initial qualitative work that they have done on recruitment. And they have a nice model of why they've chosen goal attainment as this outcome, right? So persons living with dementia with fewer unmet needs live longer at home, right? So we were able to identify what the needs are. Then you can keep the theory, you can keep people at home for longer. And they're really using goal attainment scaling as the methodology to help identify those highest priority unmet needs. And then the process of goal setting itself helps focus the plan of care, that action plan piece, to help people meet unmet needs. So I really thought I was impressed by the model here about why goal attainment is not only the right measurement, but almost part of the intervention here to help people identify and then come up with plans to meet their unmet needs. And they have an initial qualitative evaluation of 16 recruited dyads, showed high fidelity to the intervention, and have had 75% complete the intervention and rate that it was helpful to them. So this is ongoing as well. We'll be excited to see what comes out of this work. The other study I wanted to mention, and there are others, I just wanted to highlight a few here, is the GREAT randomized control trial. So goal-oriented cognitive rehabilitation for early stage Alzheimer's and related dementia. Again, multi-center randomized control trial of cognitive rehabilitation versus usual care. 475 participants with mild or moderate cognitive impairment and their family carers. This intervention was 10 therapy sessions over 3 months. And then 4 maintenance sessions in the 6 months thereafter, again, they used occupational therapists or a nurse. And their primary outcome was goal attainment at 3 months. And they did not use goal attainment scaling. They used a different goal setting scale to measure attainment. And this is, their outcomes are published. And this is from their article showing that you have the participants and then the carers, and they both showed improvement in goal attainment at 3 months and then again at 9 months. But there were no differences in their secondary outcomes of quality of life, mood, self-efficacy, or care, stress, and quality of life. And they also did some qualitative work around what were the goals that people articulated. And I thought this was very telling. Again, getting back to this construct of, we're not actually always measuring what is most important to people. And so goal attainment and individualized outcome measures is an opportunity to really understand and then move the intervention toward that. So, engaging in activities and personal projects, using appliances, devices, and the internet. We have, I think, some stigma and ageism around people, older adults, or people with cognitive impairment not using the internet, but this was a high goal, a common goal. Managing everyday activities and tasks, knowing what is happening, keeping track of information and events, locating belongings, recognizing, identifying, and naming people, engaging in conversation, organizing, improving, and finishing aspects of life and the environment. So, being able to complete tasks, leaving a legacy. Some around basic self-care, staying engaged, and managing emotions, really around coping better. So I thought, again, another example of what is important to individuals and, how important the work is moving our measurement toward capturing these things. I want to shift gears now and talk a little bit about personalized goal measurement and goal attainment scaling in clinical quality measurement. And I think we've known, as a clinician, we've known for a long time that sometimes what we're asked to measure and report on for quality reporting really doesn't fit the patients that we're seeing, right? So one size does not fit all. You can see in this, in this schema, this is the only person with a suit that looks like it fits, right? The rest of these people, it's not quite the right fit. And I think that's a good analogy for what we see with quality measurement. And so NCQA is leading some of the work here, really trying to develop patient-driven, patient-oriented outcome measures for use in quality measurement in clinical care. So this was a feasibility a study that they did, published in B&J Quality and Safety, that compared those two modalities I talked about at the beginning, goal attainment scaling and prioritized PROM, at 7 different sites, 33 clinicians, and 229 older adults with some sort of ADL impairment, and about 1 in 5, 20% or so had dementia. And in this cohort, most were able to set a measurable goal in clinical care, and about 3/4 met their goal. And they used 2 different modalities, and the goal attainment was similar with the different approaches, about 74% with goal attainment scaling and 70% with a prioritized PROM. But the clinicians much more often chose to use goal attainment scaling. And the majority of the clinicians in this study were social workers and nurse care managers. And what they qualitatively reported back was that goal attainment scaling was really valuable for care planning. It allowed them to really get specific around the goal, map out what it would look like for the individual, and come up with an action plan. It fit kind of the way that they used goal setting already, and it was a more adaptable measure for them to be able to do. NCQA has done some work around developing a provider training toolkit for this, and then this work has informed larger demonstration studies that they are doing now. As we did this work, we thought about what is the criteria for a well-scaled goal in clinical care. We see goals in clinical care sometimes, but they can be very clinician-centric. Improve this biomarker, improve your blood pressure. They may not get at what's most important to the individual, or they may not be very specific. They may not be specific enough to be actionable. So we looked at what were the criteria for using goal attainment scaling in research, and how might we then apply that to what a good goal would look like in clinical care. And so many people, I think, are familiar with the SMART goal criteria, right? And so we tried to think through what would that look like for use of goal attainment scaling in clinical care. And so, the goal needs to be specific. You need to have precision around those categories. It needs to be able to be objectively assessed. You have to understand what the baseline start, where someone is now with the goal, so you can understand then where they want to be. It needs to be around one thing versus multiple goals. You can't really put that in a scale well. And then, as you go through the scale, the difficulty level between one category to the next needs to be roughly equal. The goals have to be attainable and realistic based on the person's clinical circumstance or social circumstance. And again, it's really important that it be person-centered. That's the whole point of this. And then time bound. When are you going to follow up on it? Because that may impact the goal that you set or how you set the goal. So we actually took that construct and tried to apply it to some of the data coming out of the NCQA demonstration project. So we had about 600 or so goals from individuals with ADL impairment or serious illness, and we took a random sample 84 of those goals. The goal setting was done in either complex care management programs or palliative care programs. We had a wide variety of clinicians, physicians, nurse practitioners, our registered nurses, social workers, and health coaches. And the goal setting occurred in a variety of settings. So home visits, clinics, and then also telephone-based goal setting. And again, this is a population that had a lot of family care support. So caregivers participated in goal setting about half the time. We did train clinicians in how to do goal attainment scaling. That I'll talk a little bit about what that entails and what work we're working on to move that forward, including part of a learning collaborative, so sort of peer-to-peer learning around best practices and what's working well. This was all integrated into a clinical visit, and they could record the goals either in the EMR, a paper form if the EMR was not really set up to do that, and then also some opted to use a digital app and iPad. And here's kind of some of what we found. So appraising this concept of are the goals we're setting, are they good goals? Is this going to be able to actually be used for quality measurement? And in large part, we found that while there were some barriers and some hangups, in general, people did a reasonable job. So, they've established a baseline functional baseline status for whatever the goal was most of the time, about 87% of the time. Most of the time, they focused on one goal. They were able to do, this was probably the worst performing category here. They did have some trouble with really coming up with precise categories across that 5 scale. And they didn't actually always fill out every, the 5 points. Often they left the -2, worse, much worse than expected or much better than expected blank. Goals were usually realistic or feasible, though I will say, I think our ability to assess this from the data we received was not ideal always, in that sometimes we didn't have enough clinical context to really know. They assessed the goal difficulty, that we had both the clinician and the individual assess the goal difficulty. They created an action plan about 3/4 of the time. The goals were largely patient-centered. We had a few that were not, but largely they were. And then time-bound, we actually did not collect data on exactly when they followed up. And about half of patients attain their goals. We actually dichotomize the goal attainment scale here and define that as meeting their goal, exceeding, or far exceeding. But we come up with, and when we looked at this, we also looked at the goals and we tried to define what were some of the common problems that we were seeing. So with the baseline established, they did it most of the time, but there was some confusion about sort of this construct of improvement or maintenance. And so we had individuals would come in and they would say, I am now doing, I have this activity I'm doing, and I just want to keep doing it. So an easy example of this is physical activity. So I'm now walking, for 30 minutes, 3 times a week, and I'm not actually looking to improve that. I just want to keep doing that. And so in that situation, the baseline kind of became the level of goal attainment. And so that was a little bit confusing for clinicians. Sometimes we saw goals with multiple parts. So this is an example from our work. I want to reduce falls and I want to continue playing bingo. So you can certainly imagine a situation where someone is playing bingo and falling, or maybe they're working on fall improvement, but they aren't making it to the senior center to play bingo anymore. And so really separating those goals out. Precise levels, this was where we saw the most challenge in using this tool in clinical care. Sometimes we saw overlap between levels, or levels were not precise enough really to be objectively measured at follow-up. So be more independent in self-care. What does that mean? How would you scale that? So this is an example. The 5 category scale was sometimes challenging. We had some goals that were not realistic. This is an example: walk 2 miles in 15 minutes. This was the fastest older adult walker I've ever seen, right? Or this is maybe, not a well thought out goal. The goal difficulty sometimes would be missing patient or clinician rating. This we thought was important, not just for rating the goal or weighting it in goal attainment scaling, but also in having a conversation around, is this goal realistic and feasible, and how would you accomplish it? And what we saw, people actually would come back and revise their goals if there was if they decided that it was too difficult, and think about what might we do instead and the amount of time we're going to follow up in. The action plan sometimes would not be related to the goal or too vague, or just restate the goal. So build on current routine is an example here. And then sometimes we did see goals that were clinician centric, usually not, but occasionally. So these are examples: have the privacy form signed. Well, that's not really a person-centered goal. Or get a physical. It may be important for the individual, but it isn't really, we don't know why that person wants to get a physical, right? There's probably some other goal that's important to them for which getting a physical is a means to an end. And then having a follow-up period established. All of the goals in this study had a follow-up with 6 months, and the median follow-up was 50 days. We actually allowed them to vary when they wanted to set the follow-up. So this to say, there may be other ways to approach this. So one proposed way, this is a work by Lynn Turner Stokes, and she actually has a great practical guide to goal attainment scaling that you can reference here at this website, with this construct of goal attainment scaling light. And so she's developed this tool for use in clinical care, in rehab. And the idea here is, instead of establishing a 5-category scale, establishing a baseline and then a SMART goal. So where are you now and where do you want to be? Which I think is really a simpler construct for clinical care. And it really avoids this numerical scale and instead uses this 6-point verbal scale to assess the outcome. So was the goal achieved, yes or no? So if yes, a lot more than expected, a little bit more, or as you expected. And then if not, did you have no change? Was it partially achieved, which I think is a nice addition to this, because clinicians will often hear that, right? Well, I didn't get where I thought I was, but I got some of the way there. And this is a way to capture that. Or did it get worse? So again, allows for kind of all the possible clinical outcomes. So this, I think, has a lot of potential promise for how we can use personalized goal attainment in clinical care. And then we also did some qualitative work. Did people like this? Would they use it? What did they find valuable or challenging? And here's what some clinicians told us. So an improved understanding of what was important to patients. It helps you pay more attention to the individual instead of just focusing on the medical side, which is, I think, kind of well articulates what we're trying to get at. Aligning treatment recommendations with goals. It defines where we're headed, allows you to target care for what's important to the patient. The value of goal revision when goals are not met, right? You're not going to meet 100% of goals. So how do you have that conversation? If the individual didn't quite get what they had wanted at follow-up, I looked at it as valuable instead of looking at it as a failure, for us to see why this didn't work and then figure out how we can make it more appropriate. So really adapting the clinical care to help the person achieve what's important. Longer visit length was a barrier. So if you have too much else going on in the visit, it's difficult. So I think there's also a cultural piece here. How do we shift the care from prioritizing disease-based care and to really focusing on goal-oriented care as the priority, as opposed to a secondary thought? And then goal attainment scaling takes practice. The first 1 or 2 was daunting because I hadn't done it before. And then what about and I have patient and caregiver here because this was a clinical care setting, but really from the individual and their care about what was important about goal setting. Covered care domains beyond medical needs. My goal was more personalized and strictly medical. I did some soul searching. We discussed some personal issues with a professional that we wouldn't have otherwise had the opportunity to address. Helped set expectations. So this was a adult child caregiver of an individual. Helped me realize limitations and what was possible to accomplish. And then empowering caregivers, encouraging self-care. So allowed me to finally attend a support group by making it an actual goal rather than something I just think I need to do but never do. So that piece of action planning. So I think there's pros and cons, advantages and challenges to personalized outcomes, kind of moving into this clinical care realm. It does allow us to understand specific measurable health goals for individuals, but it takes time to do, value and time. Goals are personalized, clearly meaningful to individuals, accommodates diverse preferences, but I think we are still kind of battling this culture of disease-based care. Allows the opportunity to discuss and revise goals, and it facilitates care planning. But on the challenge may be that we want to make sure we're not doing goals for others, but really for the individual, whether that's clinician or family carers or others. And then sometimes goals may be unrealistic, but it also opens up an opportunity to talk about what is realistic or make sure we have a good understanding of disease and disease progression, to then make sure that the care is tailored to that individual. Okay, a little bit about training. So NCQA, again, has done a lot of work in this area. They've developed a toolkit, some videos, role play, small group coaching, learning collaborative. They have a website where they are kind of explain more about what they're doing in this area. And really had to focus a lot of the training on how to talk about values, care preferences, goals, giving feedback on how to use these tools to clinicians. Peer-to-peer mentoring, so clinicians who really find this easier to use or more skillful with it, mentoring others. Goal inventories may be one way to help guide patients and clinicians, and they've seen that used in research on goal attainment scaling. So this is not an inventory of all possible goals, but rather used as a conversation tool to help people kind of get out of that medical mind frame and shift into what is important to me, what do I want my care to help me achieve. Using electronic health record prompts and templates, I think is going to be needed moving forward to really move this out. And then what about, so goal attainment scaling, one of the critiques is it can be gamed, right? So do we need another clinician to really rate attainment or for unbiased assessment, which may not really be feasible in clinical care, but I think we don't want clinicians to set goals that are kind of unmeaningful just because they're easy to use, because we now are measuring them on that. Again, the organizational culture shift to promote uptake, really we're going to have local champions who will do this and do this well and can teach others. And then patient education about goal setting. So this is a different way to think about your clinical care. And so sort of priming the pump a little bit here and helping individuals become their own advocate for receiving care that is goal directed. So I wanted to also talk a little bit about some work done around best practices or research around eliciting person-centered goals. And there's lots of work in this area. This is just one example. This is done by Mary Tinetti and Anand Nayak and others around patient priorities care. And they have not focused so much on dementia, but have done a lot around older adults and individuals with multiple chronic conditions, which many people with dementia fall in that category because it is rarely occurs alone. And so this was a non-randomized clinical trial that they did, 350 older adults with multiple chronic conditions looking at primary care and actually cardiology care. They also had a VA pilot of individuals with multiple chronic conditions using this patient priorities care approach. They compared patient priorities care versus usual care. And what they found is that this approach around eliciting values and care preferences reduced treatment burden and unwanted care. So they didn't actually measure goal attainment here. They just had people set goals and do a really good job of understanding what was important to them. And then that actually then directed care around stopping medications, fewer tests that were ordered, fewer self-management tasks. And that people don't always want less care, but we do tend to give people, especially people with multiple chronic conditions, a lot of care tasks, and it can really become burdensome. So this was a way to align that care around what was most important to people. There was also greater focus on patient goals. So 66% of the visits focused on patient goals versus only 2% in usual care. Again, I'm showing you how needed this culture shift is. And what did the goals address? Well, they address those things that we've been talking about: social and emotional connections, meaningful life activities, independence and function. And they have a very nice, some very nice web-based clinical resources and templates, and I've put their website here. And then I think when we think about this work in dementia specifically, we have to think about triadic communication, right? It is really communication around the individual living with dementia, their family carer or friend carer, and the clinician that they're talking with. And there's been work in this area. This is one systematic review of 27 different qualitative studies concerning the treatment and management of dementia. Included total across the studies 261 individuals living with dementia, 444 carers, and 530 health professionals from primary care, pharmacy, nurse, caseworkers, and care managers. And they had 6 different themes that came out of this work as important, involving the person living with dementia, right? I think that really resonates. Establishing expectations of care and the roles of communication in that triad. Trust building, right? So this is probably something that needs to occur over multiple visits, so it's relational. What effective communication looks like. I think that gets back to kind of what patient priorities care is trying to get at. Continuity of care, right? Again, this is happening over multiple visits, and then understanding the relation dynamics within that triad. This is not an area where I am an expert, but I think it's really important to think about the development of triadic communication if we're going to be having high quality goal setting conversations in both research, pragmatic research, and clinical care. So this brings me to sort of some ideas around questions for future work. So I often think about when I'm doing this, is goal attainment the outcome? And I think patient priorities care is an example of that, right? So they were able to improve care delivery without ever actually assessing the attainment of goals, right? Because I think there's value in the process of goal setting and goal revision in and of itself. And we know that goals attainment scaling can be susceptible to gaming. So thinking about how we are going to approach that as we move it out. And again, I think focusing on the process of goal setting and a high quality process of goal setting is one approach there. Again, I think one of the outcomes of importance is goal coordinate care. That's that second big question is once we understand what's important to individuals, how does that impact how we deliver care? And then this construct of goal setting, improving other patient-centered outcomes. So this is where I'm putting both patient-reported outcome measures, PROMs, and also, goal attainment scaling, goal attainment in studies together. Maybe one way to address this question is, does the process of goal setting actually improve, individuals' activation, self-efficacy, improve shared decision-making, the care experience, these other outcomes that are maybe important to individuals. So really thinking about goal setting as part of a multi-component intervention. And I think we're starting to see that with the NIDA study, where it's an outcome measure, but they've actually really operationalized it conceptually as a way to improve reduce unmet needs. And then again, how does goal setting impact what we actually do in clinical care? So some more opportunities for future research. Again, best practices around triadic communication, particularly with individuals with cognitive impairment. Further development of PROMs in domains where we don't have great overlap between what's important to individuals and validated measurement tools, including both goal attainment and PROMs and trials, comparative effectiveness research like the DCARE study, quality measurement, and then considerations around dyadic measurement. I sort of mentioned a little bit around proxy report at the beginning. I think it is something we have to think through. All of these measures potentially have proxy report, and so how we think about who's reporting and their relationship with the individual, and how we think about self-report over time as people have declining cognition. And then ultimately, we want to make sure that outcomes are relevant to our payer stakeholders, right? Because we want to see these interventions that are effective, disseminated, and sustained, and reaching more individuals. I want to acknowledge my collaborators and my funding. And with that, I'm happy to take any questions that people may have.
Great. Thank you so much, Lee. We have been getting some questions, so I'll start going through those. And people, if you'd like to ask more questions, please go ahead and put them in the chat box. So there were a couple of course, great compliments, and thank you for the materials. And folks wanted to see if they could access your slides at some point. Jen mentioned that they will be available on GSA's website, along with where the recording of the webinar is. We will also link to it from our LinkAD website. Some folks asked about your references too. Is there a way that you might be able to share some of your references? And maybe if you add a slide at the end with your references, then we could have those shared too. And then a few specific questions. And let me see here. Tried to transfer them over here. So Riley's 2020 article around core outcome domains important for individuals living with dementia. Do you know if anything similarly exists for caregivers and domains that they found important to them?
I cannot quote that off the top of my head, but I bet that there are.
Okay.
I don't know of a systematic review off the top of my head, but there's quite a bit in the last probably 4 years or so that's developed around person-centered outcome measurement. I think the majority of it has been in persons with early stage dementia and early mild cognitive impairment. So I think there's room for that kind of work in persons with late stage dementia, which really then gets at carers as well. So when I put together my references, if I find something good, I'll add it in there.
Sure. And if anybody knows of anything, feel free to
Please add it up for us. Let's all learn together.
Another question was, has the light model been tested against the full model yet?
Oh, that's a great question. That light model, and this is where I would really refer you to Dr. Turner Stokes' work. She's really developed that around use in clinical care. So I don't know that her vision was ever to test it against the larger scale. I think when you reduce categories, you do change the measurement properties of that. But if you'll recall, when she uses that, she actually has 6 different categories. So you still can translate that to the score itself. So I think it is just a way to still get your 5 outcome category, but not have to use the number scale with clinicians. But she has used that to still develop a T-score around the goal attainment scaling. So people who use goal attainment scaling, you can actually develop a T-score across when a person has multiple goals to kind of give you a sense of what their overall goal attainment is, and then you can use that for a cohort. So she's still doing that, but just not with numbers in front of clinicians. So just asking clinicians to come up with the baseline and the expected level of goal attainment to then be able to use that verbal scale. So they're still checking a box. Yes, I met it, and I met it, partially, or I met it, or I met it as expected or better than expected. And then she's translating that on the back end to a score. So it's the same. I think it keeps the same measurement properties, if that answers your question.
Great. Yes. Thank you. Before everyone starts dropping off too, I want to remind people about the next 2 talks in our series. There's one on Thursday and then one next week. So please check out GSA's website to hear the other talks. A couple more questions here. This was towards the end of your talk, a question about how is this type of care paid for?
Yeah, so we really tried in our clinical work, we've tried to integrate it into true clinical care that is already part of a paid system. So, we work with NCQA, for example, these are care managers that are already part of paid clinical care, either through HMO funding, through insurers, or part of collaborative care models that may be already implemented. Or when we did it in Oklahoma, these are just existing primary care practices, and adding it to existing visits. And really the key there is prioritizing it, right? So when you have a follow-up, prioritizing the follow-up around what's important to the individual as opposed to around, other quality metrics that a physician may be asked to do. So I think the trick for payment, though, may be around training, because I think this is going to require a lot of training for clinicians. And so how we work that into models. And then I think the other piece is it does take time. And so making sure that there are payment models around time-based billing, those do exist with Medicare. The clinicians know how to use those so that it becomes more feasible, so that payment isn't necessarily a barrier to use. I think this is less about new models of care and instead taking existing models and making the care better by asking about what's important to people and using existing payment models and integrating this into them. I think maybe one approach.
Great, thanks. And then one last question, and we're almost out of time here, but do you have an example of a specific goal and a specific intervention that helped attain that goal?
Yeah, so I have a patient that I took care of, mild cognitive impairment, and was very depressed. And her goal was to increase her mobility and her activity, her day-to-day activity. And we started with very specific goals around getting out of bed every morning and making coffee, and standing and independently making her own coffee. And that's where we started. And then we worked on that was her expected level of goal attainment between where I saw her, where she was having trouble getting out of bed every morning to that. And then we worked on improving her mobility, and her better than expected was walking her dog, and much better than expected was going out to eat. And so we actually worked on improving her depression and her mobility. And we developed an action plan to work on that scale around receiving cognitive behavioral therapy from one of our licensed clinical social workers in our clinic, and then around some home-based activities that she could do to try to improve her ability to get out of bed and stand on her own, and some home health PT. So this is just one example, but standing and making coffee isn't a problem I can give her. right? And it wasn't captured in a PHQ-9 around her depression or in a functional measure scale, but was really important to her. And I think gave her a plan and a framework to really achieve that goal, and then the confidence to then move forward.
Great. Thank you, Lee. Appreciate that example. And thank you again for talking with us today. We're really appreciative of your work and how exciting it is. And thank you for connecting it with our efforts with Link AD and our collaboration with GSA. And Jen, I'll let you have the last word before we sign off.
Sure. Just thanks so much to Sam from the Alzheimer's Association and Link AD, and to you, Lee, for such a great program. We appreciate it. And I shared some resources in our in the chat. In our brain health toolkit, we can help you with the payment information. And someone had added some other chats. So check that out at geron.org/brainhealth, and you can find more about that. And we'll see, hopefully, all of you on Thursday. Thanks so much. Bye-bye now.
Bye-bye.
Thank you.